Hi, everyone. Thank you for being here. Very excited to introduce our first keynote speaker, Dr. Matifadza Hlatshwayo Davis. Dr. Hlatshwayo Davis is the Director of Health for the City of St. Louis. She received her medical degree from Cleveland Clinic Lerner College of Medicine and a master's in public health degree from Case Western Reserve University. She completed her internal medicine residency at University Hospital Case Medical Center. She went on to complete her infectious diseases fellowship at the Washington University School of Medicine, also completing a 1-year dedicated non-ACGME HIV fellowship and a 2-year dedicated sexually transmitted infections fellowship. She was a clinical instructor, associate program director of the Division of Infectious Diseases Fellowship Program, and in the leadership of the Office of Inclusion and Diversity at the Washington University School of Medicine. She was also an infectious diseases physician at the John Cochrane VA Medical Center, where she was the lead HIV clinician, graduate medical education coordinator, and outpatient parenteral antibiotic therapy supervisor. Her passion for community engagement, health equity, and patients living with HIV culminated in her becoming the co-chair of the Fast Track Cities Initiative in St. Louis, and later appointed to the City of St. Louis Board of Health. Dr. Hlatshwayo Davis is now a national and international medical contributor on COVID-19 with a particular focus on marginalized populations and has been featured in outlets such as CNN, BBC, MSNBC, and Newsweek, among others. She's also an associate editor for Disparities in Competent Care for the Infectious Diseases Society of America. Please give a warm welcome for Dr. Hlatshwayo Davis.
Good morning. I would love for you all to see me, and I'm hoping someone can help me because it's saying that the host needs to release my camera. But greetings to everyone. Greetings from everyone. I'm joining you from Johannesburg in South Africa. And I think my camera will come on in a second. Hold on, please.
Just a moment. We're trying to get her camera feed up there, and then we can get started. But Dr. Davis, you can start introducing yourself if you'd like.
Wonderful. Hi, everybody. So sorry you can't see me. But like I was saying, I'm visiting family abroad in Johannesburg. So sorry I can't be with you all. But bringing my babies to my home for the first time in my life. And so this was the one thing I said I would commit to while I was at home, because I am just thrilled to be invited. So impressed, as others have said already, by the level of organization and passion that your organizers have exhibited. I today am so excited to speak to you about achieving global solidarity by leading with a health equity lens. So a little bit about me. I was born and raised in Harare, Zimbabwe, and I do a little bit when I talk about these things because I do believe that our intersectionality as Black women, and for me as an immigrant Black woman, plays an integral role to the work that I do, and I cannot separate it. At a time where we are once again grieving the brutal murder of another innocent Black man at the hands of police brutality, it is not lost upon me that many of us Black, brown, immigrants, foreign, and other leaders in this space come to this area of passion because of our personal journeys. So if you'll indulge me for a moment, you can see from this collage that I have lived a beautiful, colorful life. My mother in the frame Hold on a second. I'm being told that maybe I can be able to pop up. The prompt for me to select my video flashed in and then flashed away again. So I don't know if someone on their side can try or to make it pop up again. But I was raised in Harare, Zimbabwe, by a beautiful single mother who is really the heroine of my story. Marcia Cannon, Mubika is her maiden name. I am the descendant of the Hlatshwayo tribe. And I do want to just give props to whoever introduced me because I have my name butchered everywhere I go, and that was remarkably well done. So my people come from a tribe in South Africa and migrated to the Eastern Highlands of Zimbabwe. So I'm the daughter of Marcia. My late father was a freedom fighter who fought for the independence of our country, then Rhodesia, and then the newly independent Zimbabwe. I'm the sister of Rutendo, whose house I'm at right now, actually, and the wife of Jesse, and the mother of Aneni and Naniso, whose names mean God is with me, and Miracle, my youngest baby being my pandemic baby. So when I came to the United States many more years that I'm willing to admit, I always intended to get my medical degree in infectious diseases. I was passionate about HIV, having seen it ravage through my home country and take the life of one of the matriarchs of my family, shrouded in what can only be called stigma and shame, which really rocked my world because our funerals in Zimbabwe are beautiful, elaborate events, 7-day events of celebrating someone's life. And she had this protracted experience, this protracted funeral that broke my heart. The reverb gone? Okay. I can still hear it a little bit, but hopefully it's not too bad on your end. But it broke my heart because this matriarch of our tribe was stripped of this opportunity to have her life honored. And that and the death of my father a few years later was really the impetus for me to go into medicine and specifically into infectious diseases. The plan was always to come home, but you make plans and the universe laughs. And I met my gorgeous hunk of a husband, Dr. Jesse Davis, and we built a beautiful family. Some of the images before you are my medical school experience in Cleveland, my co-fellows at the bottom frame in St. Louis. And then my story, I think, is similar to a lot of minorities in medicine where I did not see people who look like me. I did not have the sort of confidence to follow the pathway that okay, so everyone else can hear the echo too. Thank you, Christian, I think is making a suggestion about muting the Grand Horizon Ballroom Zoom to eliminate the echo. And so my pathway became really difficult because my confidence was stripped into fellowship specifically because there were so few people that I could relate to that not only look like me, that were different like me. As you can see, I unapologetically wear my fro, my prints. But even more than that, being raised in academia and being very fortunate to go to what I believe are some of the best institutions in the country, there wasn't, at least for me, a formative pathway that celebrated and honored people who didn't do traditional basic science and clinical research. I was passionate about public health. I got a master's in public health during med school. I was passionate about community engagement. And at the time, what we referred to as DEI, what I now focus in on health equity. And the more I felt unseen, left behind, I did not see an equitable path for promotion and advancement. And I started to lose myself. This intersected at a time in this country where a lot of inequities around racial injustice, police brutality began to arise. And I found myself pregnant, 7 months pregnant at the beginning of the COVID-19 pandemic, the only Black woman faculty member in my division, and just stunned by the work ahead of us to lead not only our hospital in the region, but really the world, right, as infectious diseases doctors in the COVID-19 pandemic. And I remember having my now 2.5-year-old baby girl. She was 2 weeks old, and George Floyd had been murdered. And I couldn't bring myself to watch the video. I couldn't do it. As a mother, I was breastfeeding every 2 hours. I had a 3-year-old in the house. We were on lockdown, so my family couldn't be there to support us. But I finally watched it. And like many people, many of my colleagues, many of my brothers and sisters in my community, a light switch went off, and my entire career trajectory changed. I came out of maternity leave, resolute to honor the path that I wanted to, even if it wasn't being honored in academic circles, and in self-advocacy resigned. I stayed on at the John Cochrane VA, 4 months later became the director of health for the city of St. Louis. But the path along the way was one of finally believing in myself and my vision. I remember looking on TV during the COVID-19 pandemic and never seeing people who look like me, never seeing women, Black immigrants, never seeing, I only saw old white men. I didn't even see a lot of people that represented our discipline in infectious diseases, and so made a conscious effort to become a medical contributor. And really my following and my brand grew through becoming a medical contributor for COVID-19, especially as it relates to equity on CNN, BBC, Al Jazeera, and other platforms. And so it was once I took on this role as the director of health for the city of St. Louis, I want to really spend my time talking to you about what we have learned at a local effort and how that correlates to the overall global calling in HIV and in COVID-19. And more specifically, how that intersected with my intersectionality and my story to really talk about what I believe has to be the path ahead. So first of all, let's talk a little bit about this idea of global solidarity. In today's world, we know we live in a global society. This is one of the biggest failings of the pandemic, was this really limited idea and this almost unrealistic expectation that we could deal with the pandemic in isolation. And we know this to be a fallacy. We know that through technology, trade, migration, and even the economy, this is one global society. And yet we know that for whatever reason, historically and COVID-19 shone such an obvious light on the fact that we still fail to treat each other as such. We saw just undeniable and unacceptable levels of inequity that persist to this day. And this lack of fundamental understanding that our interconnectedness means that when one person or one country suffers, we all do. So global solidarity to me is key. It's so important. It means recognizing our shared responsibility and realizing that our actions have an impact on others. Two years of Zoom and still. It's, to me, this concept is even truer when we talk about medicine, when we talk about my area of passion, and obviously my area of training in infectious diseases. We cannot and will not be able to address pandemics and epidemics, as well as other health issues, if we do not accept this very fundamental fact. So when the mayor called me and sort of came to me about this role as the director of health of the city of St. Louis, I had to be honest with her, because I was never going to take this role without her understanding who I was as a leader and what I was passionate about. And for me, it was this very idea of the advancement of equity and equality in medicine positively affecting health outcomes. Most of us are familiar with this drawing through to maybe the second and sometimes third frame, right? Knowing that for many minoritized communities, the reality is that folks have already started at a deficit through decades and decades of systemic and institutional racism, and other forms of oppression. We know that for a long time, we prescribed the idea of equality, and quickly figured out that that would never achieve the goals that we wanted to as it pertains to a quality of health and living for all mankind, right? Because it didn't take into account that very real difference in where we started. And so the work that we do now is one of equity, understanding that there has to be, in the same way that as there has been a disproportionate impact on minoritized communities, there has to be a similarly proportionate level of response so that we can finally get to that level of liberation that we all strive to get to. So for me, we have to redefine this idea of DEI, of equality, and really talk about health equity, because it's only achieved when every person, every single human has an opportunity to attain his or her full potential, and no one is disadvantaged from achieving that potential because of their social position or other socially determined circumstances. And certainly in this country, to call a spade, because of the color of our skin, our heritage, or where we come from. And we know that there's so many challenges that amplify these levels of inequities and inequalities, right? That there are so many inputs that have to be taken into account. The fact that everyone has a different background as it pertains to the types of resources they have, expertise, the ability to have that level of communication and advocacy on their behalf, the politics in the area, the levels of collaboration, and cultural differences that are often not taken into account. And we know that health inequities put people in a very different level of standing when they don't have that in their court, right? If you look at the infographic on the right, we know that from a global perspective, I'm currently in what people refer to as a low-income country compared to there in the United States, where we would consider a high-income country. And we know that wealth, income, power, and so many of these other social and structural determinants of health impact where folks ultimately land. So I want to just do a little bit of background on my journey, how I started as the director of health and what I came into to address. We'll take you a little bit through some of the ways that we responded locally and my thoughts about how that needs to translate globally. And so when I first joined the Department of Health in the city of St. Louis on October 18th of 2021, hit the ground running. I was expected to come up with a pediatric rollout right away. And within a month, less than a month of being there, the first known specimen of the Omicron variant was being reported worldwide. On November 24th of the same year, the WHO reported gained a report from South Africa by a prominent Zimbabwean scientist based in Botswana about this Omicron variant. November 29th, the US travel ban was issued to 8 African countries. And on December 1st, the first US Omicron case was detected, and I announced the first Omicron case in St. Louis. So I was barely had my feet wet and already had to deal with this very real case of global inequity, racism, and xenophobia right on our shores. So I want to talk a little bit about addressing that level of discrimination and xenophobia and what that looked like for me from both a personal and professional perspective. You know, you look at the textbook definition of xenophobia: fear and hatred of strangers or foreigners or anything that is strange or foreign, which differs from racism in many ways. And I'm going to shine a light on what this looked like for me. I'm a Zimbabwean woman who's dedicated her life to infectious diseases, to health equity, and is really, I carry a lot of guilt, right? The country that benefits from this, the communities that benefit from this are American. And to watch this level of xenophobia and racism happen in real time was jarring. So if you look at the infographic on I think my left, The countries in Southern Africa with confirmed Omicron variant cases, right? Israel, Belgium, Hong Kong, UK, Germany, Italy, and the Czech Republic. This was right at the beginning in November 28th of 2021. And however, the countries that were banned are to the left, most of whom didn't even have confirmed cases of the Omicron variant. I continue to watch in horror as more Omicron variant cases were detected in predominantly white countries, right? We're talking about Austria, Denmark, Germany. We went across to Italy, Netherlands, the UK, and other countries around the globe. And yet the bans remained on predominantly African countries. And this was at a time where already we were seeing an unacceptable level of global inequity as it pertained to COVID-19. We're talking less than 5% of the African globe had received much needed life-saving vaccines compared to over 65% of the North American population. And those numbers have not changed that much to this day. And so we were seeing that already we had decided that equity was not a priority, right, worldwide. A lot would refer to what we were doing with vaccines globally as hoarding in high-income countries. And then here comes the Omicron variant, for which, again, Botswana and South Africa did what they were supposed to in an act of absolute integrity and leadership, shone the light around the globe, and then were immediately punished from it, as well as other African countries that didn't even have detected cases. And what did they all have in common? All low-income countries, all predominantly Black. And so this is not how one wants to start their tenure as a director of health in a city. I already had a lot of imposter syndrome from my journey in academia. Leaving in self-advocacy was scary. Many told me that my career was over. I would never find a job again. You know, you don't stand up for yourself in institutions of this type of stature. And within a month, started self-advocacy, using my platform on social media. Again, the background story I gave you was very fortunate when I decided that I wanted to honor this journey and not become a shell of myself in academia. And, you know, as I started to do more speaking engagements, a lot more medical contributing worldwide, I built a sizable platform on Twitter and other platforms. And so joined some other equally stunned, disappointed, disgusted leaders across the world in advocacy. And we partnered with some journalists that were doing the White House press briefings to really advocate against the xenophobic bans, travel bans in social media in the United States of America. We know that this was felt worldwide. Here you see the UN Secretary General Antonio Guterres speaking to this and speaking out against this, saying we have the instrument to have safe travel. Let's use those instruments to avoid this kind of, allow me to say, travel apartheid, because that's truly what it was, which I think is unacceptable. And so we saw within a week of our outcry, and after asking two African journalists to speak up at a White House press briefing that Dr. Fauci and others were at, that the travel bans were dropped. But it was, for me, an important example to speak about how much further we have to go, how much we still face as it pertains to very real systemic and structural racism and xenophobia that hinders all of our efforts for a true global health equity, and how COVID-19 really shone a light on this. Because sometimes I think we like to make ourselves think that we're much farther than we are. I'm really proud of the work that we've done in St. Louis that speaks to what it is, what it can be like to have an equitable approach to both mitigation and vaccine efforts. And to just set the scene for you, when I joined as the Director of Health for the city of St. Louis, 74% of COVID cases for the majority of the pandemic were predominantly in Black communities, the same zip codes, North St. Louis and parts of South St. Louis. And if you took those zip codes, I asked my epidemiologist to show me how that configured when you looked at other health conditions, hypertension, diabetes, cancers, a laundry list, and it was almost a copy and paste. It was the same neighborhoods and the same levels of inequity in Black and Brown communities. So sometimes I have mentors and mentees, and I myself used to feel discouraged, how can I be from this part of the globe and not be able to help my people? How can I be in St. Louis and predominantly helping folks there? And what I love about the work of health equity is that the blueprint that we have in cities like St. Louis is a blueprint that I think is very relatable, transferable, and for me has been a source of collaboration, and we'll talk about how. So I told you a little bit about that first case of Omicron that we detected. One of the things that was important to me as I considered not only a vaccine rollout, but also a robust response to the Omicron surge that we all know was the greatest surge in the history of the pandemic, was we weren't going to get there without engaging the leaders that are trusted in these organizations. Even though I'm a Black woman, even though I look like many of the people in the communities that we talked about, they didn't know me from a bar of soap, right? I had been at WashU and only in St. Louis for just under 10 years. But there are leaders who had been doing this work for decades, right? Never get the glory, don't get the funding, but that are trusted. These are the pastors. These are the faith healers. These are the grassroots community organizations that have earned the trust of their communities. So the platform that I the basis for our rollout was one of centering community partners. I went to the large academic institutions and I said, and I've always said this to them, try to break the ice and say, listen, it's reparations time. And your reparations is to, number one, fall to the background and be the supporting cast, and B, provide the infrastructure and the funding to now allow the federally qualified health centers who have earned the trust of their communities, the faith leaders who have earned the trust of their communities. You will provide them with the infrastructure for them to take the lead. And our mitigation and vaccine efforts have tripled from that time forward. My largest vaccine clinic was done in North St. Louis at one of the most longest standing Black Baptist faith healers, Pastor Burke. It was in the middle of winter during the Omicron surge. And I remember being in awe at seeing he had a mobile outdoors church, because he was trying to be respectful of COVID-19 mitigation strategies. So folks would drive up in their cars. It was blocks and blocks of cars, and come through to get communion and to get a blessing from their pastor. And then we set up our mobile van on the opposite side, and people would get communion, get their blessing, and get their COVID-19 vaccines and boosters. Largest turnout we've seen during the COVID-19 pandemic, because they came because they know and trust Pastor Burke, not me. I rolled up my sleeve and decided that my staff, when I inherited the health department, it was a quarter of the size that it should be. It was understaffed, and it had a fifth of the budget that it could. Public health is in crisis. Even though we should know and we should respect from the COVID-19 pandemic, the mpox and other onslaughts since COVID have shown us that there still isn't a healthy respect for public health, and specifically pandemic efforts. And so one of the things that was also important as a leader was to prioritize healing within the department. My staff said, we are burnt out, we are undervalued, we are underpaid. And so it was in the middle picture that you see there is me giving my staff their own boosters, their flu shots myself, so that they knew that while I'm asking them to do this incredibly difficult work, I honor them and we value them, and we still want them to be okay and to be taken care of. It was going to the mayor and advocating for salary increases, going to the Department of Personnel and making sure that we found ways to incentivize their works, honoring mental health and getting people in to come to talk to them about self-care. Because we think about this work, but we oftentimes forget the very real people who are underpaid. I remember the first raise that I had to give my second week, I sobbed when this woman left my office. She was a food inspector who worked 12 to 16 hours a day, got harassed at restaurants, and I was giving her a salary increase of $35,000 a year to $37,000 a year. This is what we're asking the people who do the work of public health and really saw us through these pandemics to do, and it's unacceptable. And if you think about that in terms of St. Louis, Missouri, one of the largest cities in the United States, what more in low-income countries? And so when I talk about global inequities, a lot of people just think about vaccines, but it should have been a wraparound approach to global COVID efforts that are founded on equity, that included funding to support health workers, to support communication and education endeavors, to manufacture their own vaccines, and to roll out those early vaccines. But none of that was the case, and only superficial efforts to donate vaccines. And and it was interesting. I remember speaking with ministers of health at the time, and they would say to me, yes, we've heard about the millions and millions of vaccines coming from the US, from parts of Europe, but a lot of times they would be a week before they expire, and we didn't have time to get them out. Or it would be, you're sending us vaccines, but there's so much mistrust and distrust, and nobody's talked about or thought about helping us with misinformation and disinformation efforts. I was one of the last health directors in the country to still have a mask mandate up. So we then talk about how the COVID-19 pandemic really showed how politicized this issue had become. And so we dealt with that as well. And really the education portion of equity is one that I think is overlooked as well, and has to be led again by those trusted messengers using the culturally competent approach to education. So let's talk a little bit about the path ahead, giving some of those examples and some of the things that we did see. We have to know moving forward, and we've already failed, because with Mpox, I don't know that we took some of those lessons learned, but race, gender, nationality, viruses don't discriminate. They don't see that. Access has to be key, and empowering folks to be able to manufacture their own vaccines, to have the funding for education and rollout, and to be thoughtful about how access differs in Johannesburg than it does in Egypt, than it does in China, than it does in St. Louis, Missouri, and leaning into the expertise of the local leaders who know what those challenges are, right? I remember in St. Louis, it was so well-intended, right? Let's put masks and at-home COVID tests in pharmacies. But if you had gone to any local grassroots organizations, they would have told you that most of the people in North City live in pharmacy deserts. So while it helped predominantly white St. Louis, while it helped the folks that could afford to order tests from Amazon, it did not help the very people, the very same zip codes that are a copy and paste from COVID to HIV, to STIs, to diabetes, to hypertension. So when we talk about access, who are we asking? My good friend, Dr. Corey Bradley, always says data is justice, right? It's justice because it helps us to inform policy and to ask for funding. But I remember I used to always, be so flashy and be like, data is justice, data is justice. And a community leader said to me, boy, you academics love to throw around data when you talk about equity, but you don't even come to us to ask us what the important metrics are, what the variables should be, and what the outcomes we should be looking for are, because you can make any study, any outcomes, any piece of data serve your very needs, and it can still be discriminatory even when you think you're operating in terms of health equity. So it's so important to talk to the very communities and the people on the ground so they can inform what our approach to data and then our approach to policy and access will be. Governments have to commit to providing funds, resources, and personnel to support both local and global countries. Just watch right now Congress dry up funds for COVID, right? And to think about who immediately suffers. If we privatize, right now the conversation is privatizing COVID-19 vaccines. If we privatize vaccines, I'll be okay, right? I'm a physician, I have full insurance, I have access, right? But those same communities in North St. Louis I talked about, those same zip codes, what happens to them? What happens to the children in those jurisdictions that needs boosting? What happens to the elderly in elderly living facilities across St. Louis that are predominantly, again, minoritized and enclosed living settings that now no longer have funds? ARPA funds, American Rescue Plan Act funds, billions of dollars went out across the country. And they've lasted through 2026. What happens to the immunocompromised, the elderly and minoritized communities now that those funds have dried up? It means that those same inequities that we work so hard to close, because we did do a fairly good job in the United States of addressing some levels of inequities, right? We tried innovative things, $6 billion towards community groups, FQHCs, from the federal government. You have to applaud that, right? As much as pharmacy deserts were an issue, the efforts to diversify access, pop-up clinics, and empowering grassroots organizations. So we know that steps were made, but if we suddenly dry up that funding, what happens to those very same communities? We all know what does. Those levels of inequities that we took so much time to try to address widen. We have to invest in research, development, and delivery for new vaccines, treatments, and diagnostic tools to achieve global public health solidarity. And again, what works for us in the United States may not be what works across the globe. It's very interesting. A little known secret is that most African countries actually had what would be described as a much more successful COVID-19 strategy. And if you look at a lot of the papers that were released, it talks a lot about genetics, right? The fact that a lot of African countries are predominantly young. But what I saw, because I had to visit my sister, the one time I traveled globally during the pandemic was to come for my sister's wedding. And I saw a few things that I didn't see in the United States. I saw a unified approach as opposed to 50 states that have their own level of autonomy. I saw one band, one sound. There were police in the streets. My poor mother, a single parent, a grandmother, was in our house alone for months and months and months. You couldn't go to a store. Every store I went to would ask me for my mask, and there would be hand sanitizers outside of every grocery store, right? There was a much more unified, robust, concentrated approach to dealing with public health, right? And that wasn't really celebrated or talked about. And the thing that failed a lot of low-income countries was that level of disinvestment in research, in the development of those vaccine hubs that we heard so much about and that we were supposed to invest in so that they could create their own vaccines, and in culturally competent ways of dealing with treatments and diagnostic tools, right? In releasing patents, in coming up with, in prioritizing the creation and delivery of treatments that were cost effective in these countries. That is where we failed our brothers and sisters in predominantly low income countries. So moving forward, leaders must prioritize the protection of our most vulnerable populations, including people of color, those in poverty, and those in low income countries across the globe. For me, if we do not wake up to the fact that this is one country, I mean, one world, one community, if we do not work together, if we do not prioritize creating a world where everyone is safe and healthy, this hits home for me again as a Black mother watching disturbing videos of a Black man, you know, crying out for his mother in his final steps. If we don't address the multiple levels of systemic and structural racism, oppression, that remove color within the halls of where they were perpetrated, right? We saw 5 Black police officers inflicting this on a young Black man. If we do not understand the depths of the roots that start from slavery all the way up to present day, and truly understand that unless it is 65% across the globe and not less than 5% vaccinated in Africa compared to 65% across the globe, we'll never reach this goal together. I want to thank you all for the honor of being one of your keynotes for today. I look forward to any questions and discussions. And yeah, we'll move to those now.
We have mics on either side of the room if anyone has a question.
Hi, thank you. Is this on?
Yeah, I can hear you.
Oh, thank you so much for this wonderful talk. Really appreciated this sort of perspective on global, local. I just had a question about just thinking back on all the news media of COVID coverage and how the international coverage was just so meager, if I can say it that way. So, you know, there wasn't a way to get that sort of outrage that you're talking about because it was just completely subsumed by the local picture and people's concerns about their own well-being and speaking to their own fears during the pandemic within the United States. And so I was just wondering, I mean, I was even actively looking for it, and it was hard to find that information about the kind of gross inequities that you talked about in your talk. So I think that's one of the things is just in terms of the narrative, how much the news media just kind of like plays into it, and how much in order to get people, you know, galvanized and sort of outraged beyond the borders of the United States, part of it is just having that information, which was so hard to find.
Yeah, you couldn't be more right, and I'm so thankful to you for pointing that out. It was, again, you know, nobody wants to be a new mom with all of the extra weight that you have and be straight on camera every other day on live news. But it was one of the reasons it was important. And what's funny was representation was so key, because I remember being sort of chastised and advised before I went on the news, and I was told, you know, we like people who wear their hair straight back in a ponytail and wear pastel colors. And I was like, okay, hold my beer. And you know, arrived on CNN in print and froze, and I've been there on Bantu knots with braids. And I can't tell you just how that level of representation alone, I get letters from across the globe from people who say, thank you, I've never seen someone like you, I've never heard from, and they'll listen because it's someone they relate to. But there's a big issue as it pertains to muting the true global crisis across the globe. For many people in this room, I'm sure the issue around travel bans was not as distinct, maybe was not as prominent. And that's because we know that media is very closely linked to politics and to the priorities that are put out, right? And so we don't value, quite frankly, the suffering of people across the globe. It isn't a catchy headline. And more importantly, it isn't part of the priorities set forth at our highest level of government, right? And so it requires that level of advocacy. And it's one of the reasons why it was important for me to honor the speaking engagement, even though I am away, is because it is programs like yourself, global health educational avenues that will breed the next generation of leaders. I recently wrote an article with Dr. Esther Chu in BMJ right after the midterms, just talking about why coming out of a pandemic, health was still not a priority. If you look at Kaiser always does amazing, as you know, as some of you may know, Kaiser does an amazing job of keeping up with COVID-19 statistics and health statistics through the pandemic, and has now got a whole equity level as well. But Kaiser did an amazing job of keeping up with the data as it pertains to what folks prioritized when they went to the ballot during the midterms. And public health, specifically as it pertains to COVID, health equity, was really low down. Reproductive injustice was one of the higher ones, understandably so, and then gun violence as well. And there is an amazing quote that I by heart, but it is from the dean of the School of Public Health at Harvard. And she talks about how if we have to train our politicians, all politicians should be required, and I believe also media leaders as well should be required to take courses in basic public health, because there is so much research out there that shows the link between a thriving economy and public health. I'll give you an example. I have 1% of the city's budget in the city of St. Louis. The WHO sets a threshold, a low threshold of 5%. There are low-income countries that prioritize public health in their cities more than St. Louis does, right? That's in comparison to 4% of parks and streets and 52% of public safety. The police department gets 52% of the city's budget compared to 1%. They always defend themselves by saying, oh, we do surveys and people don't prioritize public health, because again, there's a health illiteracy problem. So to get back to the point of your comment and question, when you couple a gross level of health illiteracy, especially in minoritized and impoverished communities, with the need to have political priorities take the priority of the press, and the fact that we just don't care about people outside of our borders, we have a real issue here. And the only way to change it is to do exactly what you all are doing and breed the next generation of global health leaders across spectrums, so that when we are voting for folks, there are folks that understand the pivotal importance of the fact that if you do not have a healthy society, a thriving healthy society, everything goes to hell. I see there's a question in the chat from Christian Yanis. I hope I'm not butchering your name. Two questions. What are some of your reflections on your first 2.5 years as the Director of Health for the City of St. Louis? And two, what are some learnings from international approaches and successes to addressing COVID? So for the first, I've only been in for 1.5 years. It feels much longer. And I would say again, I came in with lofty goals. I knew that I didn't have the luxury of picking COVID versus non-COVID priorities. I had to in parallel deal with COVID, again, the pediatric rollout, the Omicron approach, and then trying to help people understand that you can't just switch off a pandemic, and that it would take time to transition from that pandemic to endemic phase. In parallel with non-COVID priorities, which in the city of St. Louis, as I see it, are behavioral health and mental health, gun violence, and then chronic diseases and STIs. And so I had to focus on that in parallel. However, I quickly was humbled at my first staff meeting, where I had this amazing plan to talk about missions and goals and building them together with my staff. And all I got was over and over again, we're tired, we're burnt out, we're undervalued, we're underpaid. And I have broken a record in my first 1.5 years of being a health director of hiring more people than any other director. I've hired 65 people in the first year, which is hard because you have to live within the city of St. Louis. And again, the county health department next door to me can poach people from me and offer them almost double the salary. That's how little people get paid. So I've hired 65 people, but in the same amount of time, I've lost 40. Think of that level of turnover. We are losing people in public health because they're so burnt out and so undervalued. And so to me, that reflection, us really prioritizing rebuilding public health, really focusing on work, recruitment, retention, rebuilding infrastructure, and prioritizing high-level infrastructure as it pertains to emergency preparedness, technology, lab services is going to be key if we're going to be in any way equipped to deal with COVID moving forward. The dollars have dried down, and to really honor the global society. And then for your second question, learnings from international approaches and successes to addressing COVID, it's again that fundamental understanding that there has to be one unified approach. The way that we allow 50 different voices, and then there's 3 thresholds, right? The federal government, the state health departments, and then local health departments. Local health departments, we are local public health. We are the enforcers, and yet my hands are often tied because if critical funding and resources are not released at the state level, and again, and if not at the federal level, where we've seen a real implosion of faith in the CDC because of a lot of reasons, which I won't get into, but we know one of them is being undermined, seriously undermined at the federal level at different times. Those to me are some of the things that need to be addressed. And when I look at other African countries that have been successful, it's kind of in that one band, one sound, that African CDC is not, you guys should have a talk alone on how the African CDC addressed misinformation, disinformation, getting data out, and culturally competent interventions within communities. It was really aspirational.
Thank you so much, Dr. Hlatshwayo Davis. We really appreciate your thoughtful presentation. I don't know if do we have time for one more question? Okay.
Thank you so much, Dr. Hlatshwayo Davis. I won't take up too much of your time. I just want to say thank you so much for your presentation. As a Black American young man and son of 2 immigrant parents from Jamaica, like, it really resonates with me, and I feel empowered by your presentation, your testimony. My question is about, your notion on accessibility, right? You talked about how we have to go to the communities, especially communities of color, to give them the access to being in research, right? Being represented in some of the studies within science research. But I wanted to ask you more about the other side of accessibility. We can go to these communities, we can go to the stasis points, which are like churches, local clinics, some of the hubs of being a community, but how do we make it accessible to individuals who work long hours, who don't have that ability to participate because they're supporting families, supporting other people around them that rely so much on them? How do we work within their schedules, their parameters, if they want to partake but aren't able to? And thank you.
Yes, Young King. Yes, Young King. I love that question. And let me just say, the camera panned to you. You look sharp. I see the suit. I see the hair is thriving.
I'm blushing right
I'm
now.
loving what I'm seeing. I'm seeing it all, and I'm proud of you, Young King. So what I want to say to that question is such an important question. God, I love that question. And I hope you reach out to me and email me, because I'd love to connect and hear more about what you're doing. But we do this, right? We take academic concepts and we try to translate them into communities. And I think one of my superpowers that I didn't appreciate in academia, because it was muted as a soft skill, right? Because I wasn't a basic scientist, a clinical translator, is I love people. You can tell I love to talk. I don't give talks that are overly academic. I come and give real talk, let's have a conversation. And I take that into the community, right? And people resonate with that. So one of the first things, I think the biggest area that I've grown in my department, I focused on 2 of my bureaus, right? And that is the communications bureau and then my epidemiology bureau. I had 1 epidemiologist for the whole department. When I started, we have 10 now. And then I grew my communications hub, and we had to meet people where they are. That means I had to be accessible. Listen, I'm an auntie at this stage. I like to think I'm young, but I am as corny comes on social media. But I'm here in these Twitter streets. I'm on IG. I'm doing live talks. I'm getting an intern to get me on TikTok. But I also did town halls throughout the pandemic. And I reached out. We have aldermen and women in our government infrastructure. So there are these aldermen for each district. I made sure they didn't get a lot of communication from past directors. I give them a monthly report. And I also offer myself to come to neighborhood meetings and just talk public health, make public health accessible. I have 2 young girls, 6 and 2. Sometimes you'll see me on the weekend with the girls at community events. But I had to cross the divide and think about the fact that not everyone has access to the internet. So even though I would do a Zoom town hall, I was also there in person. I made myself accessible to local news. Nobody cares about my BBC and Al Jazeera in North St. Louis. They know Shirley Washington, who's been on the news for 50 years, child. And so I make sure I'm on Shirley's channel. I make sure I'm on The American, which is the #1 Black-led newspaper in the city of St. Louis. They get first access to me. I make sure to invite them to our events. And so we had to really diversify access. But you also have to put people who actually like to be around people. And that's not everybody's calling. Some of my best people, they're data crunchers, they're behind computers. I just hired the best commissioner of health. And she said, listen, I'm the yin to your yang. I don't do interviews. I don't want to be on the news, but I'm going to build infrastructure within the department. So it was also hiring a great group of people, even a small team, and understanding their gifts so that I like to use people's talents where they're needed. And in community, you have to have people that love community, that speak the language of community. And I'm humble enough to say I've only lived in St. Louis for 8 years. So again, I have to partner with Pastor Burke, with the Integrated Health Network, which is the longest standard equity-based grassroots community group, with the Regional Health Commission, with the Ferguson Commission, right? That marched in Ferguson during the uprisings, right? And are now trusted leaders in the community. So I don't move without them. I don't do vaccine events without the Urban League. You feel me? So it's about trusted partnerships. It's about meeting people where it's at, and it's about diversifying how I reach people.
Thank you so much, Doctor.
Thank you, Dr. Hlatshwayo Davis. Can we give her a
It's
round
the
of
killing my
applause?
name for me. You all, I will come back anytime. Thank you all.